As part of our Next Steps Into Adolescence workshop, we offer information about medical treatment for autism spectrum disorder. Eron Friedlaender, MD, spoke to an audience in the spring of 2015 on this topic. Watch and listen to Dr. Friedlaender discuss medical aspects of autism spectrum disorders in adolescents.
Hi guys, so thanks for having me here today. I love to come to these because it's really helped me as a parent. I'll tell you a little bit about myself because it will help explain why there's an ER physician standing up here in front of you. And this time is really meant to serve you and answer your questions. And this is a little bit of a hard topic for me to address because it's so broad and there are so many ways that I could go. So I try each time to talk about the things that the prior groups have asked to hear about, but if there's things that you want me to try to focus on or bring attention to, please let me know. So as Gail said, I'm an ER physician at CHOP, and I have a son who's 12 on the autism spectrum. And I came to Gail several years ago, I think when Alexander was 9, and I said, I don't know what to do because he's getting bigger, and the first Next Steps workshop only took me so far. So please help me know what to expect. So she said, well, let's sit down and we'll write something so that we can address this for you and everybody else who has kids out there. So here we are today. My son, as I said, is now 12, but I had noticed that over the years he had a couple of things that brought him to the hospital. He had an open fracture of his arm, and we had some complications from that he had a hard time articulating what was wrong, and it turns out there was, a big problem that had happened as a consequence of the surgery that after 4 or 5 times, finally somebody paid attention. But I realized that we as a medical community have a very hard time interacting with kids who communicate differently or feel things differently or get anxious and then we don't know what to do. So I have tried very hard over the past several years to identify the barriers to what makes us successful in our interactions with kids with autism and try to make efforts to accommodate and facilitate things that make kids more comfortable in the medical environment. And so that's a big project of mine, and I think we've done a really good job of bringing greater awareness to the people at CHOP and how to interact with our kids. So please let me know if you have ideas or if you've had experiences that have been really good or really not so good, and we'd love to build that into our programming. So I am supposed to talk to you about how the medical community interfaces with kids with autism and the kinds of things you might experience from medical providers and medications. I think that you may be reaching an age where your kids are developing additional symptoms or complaints may not be the right word, but additional kinds of medical concerns that may bring you to interface with gastroenterologists or gynecologists or neurologists. So we'll talk a little bit about who those people are and why they might be helpful at different stages in your care. There are many, many, many things I'm going to talk about as comorbid diseases for kids with autism, and by that I mean there's a constellation of medical concerns that seem to cluster around kids with autism and tend to sort of tag along. I talked a little bit about integrating care and advocating for accommodations. The biggest thing I want you to take away with is you guys know your kids best. So when you bring them anywhere, it's as, to the best of your ability, your job to tell those of us on the other side of the room or the mattress or wherever we are in the room, what works for your kid, what doesn't work for your kid, what you see that's different, what you're worried about. Because, again, that's our role as parents. And then we'll talk a little bit about the use of medications. And it's not my job to stand up here and tell you to medicate your children. A lot of families have great struggles over when and which medications to use. So I'm just going to sort of introduce you to some of the most common medications for those of you who are considering it. And maybe it will help sort of start a conversation with your physicians or the people in your family about when it's right. So medical treatment of autism. This is, again, a hard topic to address because there have been quite a few changes in how we even define kids with autism. And as we know, it's such a spectrum of disease that a lot of studies are done with just kids with autism. And it's kind of hard to know what that means, right? Does that mean classic severe autism in a nonverbal population? Does that mean anyone who fits on the spectrum? Lots of medical studies haven't really paid great attention to trying to refine which population of patients with autism they're dealing with. So it's a little bit challenging to sort through that. So a lot of this is just general information about autism, and we don't necessarily know if it's different among kids with classic autism or kids with high-functioning autism, or whether it's the same throughout. So I just sort of put that out there as this is still evolving. A lot of what we try to do is help to manage the behavioral symptoms that come along with autism. So problem behaviors, self-injurious behaviors, disruptive behaviors, the things that really interfere with our kids being successful at home and at school. And then a lot of medications or medical interventions are meant to help improve health-related quality of life. Again, we can't make behaviors go away. We can do our best to understand them, and we understand that this is a function of a disability and oftentimes a lack of ability to communicate as effectively as the kids want to. So sometimes medications can just help decrease anxiety and agitation around those concerns. And again, making kids more comfortable allows them to access the behavioral and educational interventions that we try so hard to put in place for our guys. So I talked a little bit about these comorbid states that tend to cluster around our kids. They are not simply related to kids with autism. These are, in kids with all different types of baseline disorders and in very neurotypical kids, but there are things that come to attention with great frequency. So motor impairments. We have lots of kids who have fine and gross motor delays, kids who have trouble with coordination. So you're going to be interfacing with probably neurologists, occupational therapists, physical therapists around those things. Turns out 56% of kids with autism have some kind of sleep dysfunction, which means you and I have sleep dysfunction. If they can't sleep, we can't sleep. Neurologic concerns. So we're going to talk about this a little bit more because seizures is something parents have a lot of concern about. So depending on the studies that you read, between 25 and 40% of kids with autism will have epilepsy, which is a seizure disorder. And that's compared to 2 to 3% of the general population. That's extraordinary. GI concerns. Again, the literature reports rates between 17 and 85% of kids with autism are going to have some kind of gastrointestinal concern. And for me, again, in my own home, my biggest worry was nutritional deficiency because my kid ate 3 things. He ate plain noodles, he ate pizza, and he ate strawberry yogurt, probably for the first 8 years of his life. Psychiatric. So 80% of kids with autism are going to have some kind of comorbid psychiatric diagnosis. That is also an extraordinary number. And then we're going to talk a little bit about injuries because that's my home in the emergency department, so I know a little bit about that. And then I wrote obesity here. For the first time, I think, the CDC published literature last year that diagnosed 32% of kids with autism as being obese. That also is remarkable, and they compared it to other populations of kids. So 32% of kids with autism are obese. 13% without any kind of developmental disability are obese. So that's a pretty big gap there. And it's also, they compared the rates of obesity. I'm just looking at my numbers here. Obesity rate is 20% in kids with any learning disability or developmental disability overall, and 18% in kids with ADHD. I hope so much one day to be able to stand up here and say that we now understand the biologic basis of autism, and we just don't right now. I think it's great people are thinking about it. The stuff that I've seen that talks about why kids with autism are largely obese compared to other populations is in part the use of atypical antipsychotics can contribute to weight gain, right? I think that we certainly have trouble getting kids to eat well. We have trouble getting kids to eat a varied diet. We have trouble with kids with obesity. And again, one of the other explanations for the obesity rate is, our guys aren't as social. They're not able to engage in a lot of the kinds of team sports that kids do at this age. They're socially isolated. They have coordination problems and physical therapy problems and executive function problems. So how do you navigate on a soccer team? I think that this is still being sort of investigated, but it's a problem, and knowing that it's something to look out for maybe will help us figure out how to keep our kids healthier. All right, so in the emergency department, there have been a couple studies that have come out recently that show that injuries among kids with autism are a little bit different in terms of the patterns that we see among kids without autism. We see kids with higher rates of head, face, and neck injuries, and more significant things like fractures and burns, and less common are things like sprains and strains. And again, I'm not sure why. We don't have great information. Some again say, oh, they're poorly coordinated and they fall off things, or they're not as active, so when they are active, they hurt themselves more. I think there's 100 explanations. We don't quite know. It's just so far what we're noticing. We see that there are almost 8 times the rate of poisonings and self-injury complaints that come to the emergency department with kids with autism. And when I use the word poisonings, that doesn't necessarily mean what we might typically think of as a poison. It might mean an unintentional overdose of a drug. It may be an intentional overdose. We have lots of kids with depression and anxiety, and that's a common suicidal gesture among kids. And then it can be the same kinds of things, kids eating hair relaxer, or putting things in their mouth that are considered toxic but wasn't an intentional attempt to expose themselves to something harmful. And then we have a huge population of kids with autism that come to us in the emergency room because they either are in a behavioral crisis or a psychiatric crisis. And we see that kids with autism who have behavioral concerns have what we call externalizing behaviors, aggression, disruptive behaviors, much more commonly than internalizing behaviors, which are more common among neurotypical kids, so sort of depression and sort of isolation. And then we see that kids with autism come to the emergency department 9 times more often than neurotypical kids for psychiatric concerns. That's extraordinary, I think. So 13% of visits that come to the emergency department for kids with autism are there because they have a psychiatric concern. In the general population, that's 2%. 2% of visits are for psychiatric concerns. So again, I think this reflects lots of things. Part of it is we just don't have enough community providers who understand our kids and know how to help. Lots of families need respite care, and the emergency department is where a lot of families feel safe coming. So this is oftentimes what we are managing, and why I'm doing the work I'm doing, so that we can sort of help get them the care that they need in an uncomfortable environment, such as the hospital. Okay, so medications with autism. Again, we talked about how many kids have a coexisting psychiatric illness. 35% of kids, just in the studies that are done with the literature that's available, suggest that 35% of kids with autism are on some kind of psychotropic medication. We all know that there's no medication that's going to cure autism or take away the things that make our kids suffer, but a lot of the medications can help make them more comfortable. And we consider them complements to the other kinds of interventions that we do. They don't serve as a substitute, but oftentimes they make the other things that we do more accessible and more accessible. So again, as I spoke of, we have some limited understanding, in part because kids have inconsistent symptoms. Kids aren't able to necessarily describe in their own words what they're feeling and how their feelings might be changing, so they depend on us to be their observers and to sort of interpret their behaviors. There aren't a whole lot of scientific studies that are considered sound research, so there may be lots of things out there that are suggestive, but if you look at the methodology, sadly there's a lack of really good rigorous study. And I think that autism, as we know, and we've talked about it a lot, when my son was diagnosed 10 years ago, we didn't talk about it like this. So it's still a relatively new field of study. And so when we think about looking at long-term effects or how things sort of work over decades, we don't have that information yet. So we're really working with limited information. The medications that we tend to use are meant to treat, like I was saying, a lot of the core deficits and a lot of the related behaviors that our kids have. So kids have inattention and impulsivity as part of autism, right? That's part of the core deficit. Kids can also have ADHD as a complete additional diagnosis. And so we try sometimes to manage the symptoms of inattention and impulsivity with a whole host of medications. And I think this is probably what people need the most help with for kids with autism. And it can also be quite a long process in trying to find the right drug. So the biggest message, I think, from this little piece of the talk is that if one thing doesn't work, there's probably 25 more to try, and to go into it with the idea that, again, it's a process, and you just need to have a partner and a physician who's willing to sort of work through all of this with you. We use different classes of medication. So some people start with the stimulants, and there's a good bulk of literature that suggests the oldest form of Ritalin, the methylphenidate, works best in kids with autism. Again, there's so many different ways to think about these medications, and there's so many ways to offer them. They come in short-acting and long-acting and extended release forms, and some come as liquids and some come as tablets. So it, again, requires a lot of conversation with the patient provider who's going to listen to what the needs of your family are. We also have the non-stimulants, so things like Strattera and 10X. And then we have sort of not your first line, but a little bit further down, medications like antidepressants that we use typically for mood disorders, and other populations have been shown to help ameliorate some of these side effects in this population. We talk a lot about aggressive and disruptive behaviors, rigid behaviors, stereotype behaviors. And again, there are lots of different kinds of medications that can address these concerns. I'm going to just put up this slide about typical antipsychotics, because as an ER physician, and having just reviewed with you how many kids come in with agitation and really aggressive, out of control behaviors, sometimes the answer in our environment is to give a rapid acting medication that will quickly de-escalate behaviors when kids are at risk for true harm to themselves or others around them. And sometimes that's a conversation that has to happen quickly, so I think it's nice to just know that there is something available that we can give. And what we tend to reach for, unless you guys come in saying you know what works for your kid really well, sometimes what we go to is a medicine called Haldol, and sometimes it's a medicine called Ativan. And those aren't what we necessarily want to do, but sometimes that's the answer to quickly sort of make things safe. But these are not medications that we use for maintenance care. Instead, we have a new generation of antipsychotics, and that's probably an uncomfortable word to hear. It's just a name, it's just a word. It's used for psychotic behaviors in people with other kinds of psychiatric disease, and I think kind of by accident, we found that they can also work for our kids with aggressive behavior. So if that is offered to your child, it is not because people think they're psychotic. That is not what we're treating. They just sort of work in other ways as well. And the two that have been approved by the FDA are Risperdal and Abilify, both of which have significant side effect profiles. So this is, again, an opportunity to sort of think about how much benefit you get and how much you're giving up. And we do that with every single medication that we try. But these have really transformed the experience for many families from being dysfunctional to actually being functional. We talk a little bit about using one medication to treat something that it wasn't intended for, and this is another good example. So the antihypertensive medications, so to decrease blood pressure, we're not looking to decrease blood pressure in our kids, but sometimes they also have a bit of a sedating effect, and they can kind of rein in inattention and disruptive behaviors as well. And many people are on multiple medications, and oftentimes using things synergistically or in combination works even better. And that's really hard to put your kid on medications. And I know that as a parent, and I know that as a provider. But again, this is not meant to tell you to do it. It is just meant to allow you to know that this exists. The antidepressants, again, the literature does not so much reflect that they're enormously helpful in changing depression among kids or in changing behaviors, but they do make some kids more comfortable. Kids with significant anxiety, kids with really significant depression as they age into adolescence and sort of see how different they are. I think people tend to use them even without a huge amount of robust evidence that they're enormously successful because they have such a safe side effect profile. And so lots of people are very comfortable trialing them, knowing that if you stop them, the side effects can go away, the side effects are mild, and sometimes the results are brilliant. And then, again, we'll talk about seizures in a little bit. One of the sort of silver linings, perhaps, is that in kids who have both seizures and autism, there's a class of medications that can treat both. And those are the antiepileptics that I've listed here. So specifically Lamictal, I know, has been used to help both stabilize mood and to treat seizures. You can use these to treat mood in the absence of seizures. They're just not necessarily a first-line medication. And many of these also require things like blood tests to monitor how they're affecting your liver or your kidney function. So it's not optimal, but you can see how many choices there are. Seizures. So seizures are transient and involuntary changes in your level of consciousness, in your behavior, in your motor activity, in the way you might be feeling in your body, or in your autonomic functions. And it basically means the discharges in your brain are firing beyond your control and making you do things that you're not intending to do. So it's the most common neurologic disorder of childhood. So 4 to 10% of the general population of kids are going to have a one-time seizure. And then in the general population, epilepsy, which is the idea of having more than one seizure, sort of an ongoing seizure disorder, occurs in 2 to 3% of the general population. And I'm going to remind you of these numbers because it's pretty dramatic when you compare to the rates among kids with autism. So I guess we're running a little slow on late on time, so we're going to go quickly through different seizure types. So seizures can look like lots of different things. There are many, many seizure types. As physicians, we're not always very good at being able to look at a kid and their movements or their behaviors and know whether it's truly a seizure or not. I think we're right about half the time. And so there are very definitive ways of identifying what is a seizure and what isn't. All seizure types have been noted in kids with autism. There's not one particular variety that tends to sort of accost our kids. So 6% of children with autism will have a one-time seizure, which is enormously consistent with the rate in the general population, which is 4 to 10%. But again, it's up to 33. Some studies show even greater, closer to 40% of kids with autism will develop epilepsy. That's tenfold, right? So that's huge. And that has sort of provoked a huge amount of study into why there might be a shared genetic basis. And I think it offers a lot of insight that this is really a neurologic disorder rather than a psychiatric disorder. And that helps us understand a little better where the symptoms of autism might be coming from. So we see kids with seizures present most commonly either when they're toddlers or sort of around the time that they enter puberty. And we know that there are a few things that put kids at higher risk for having a seizure disorder. So kids with associated intellectual disability, kids who have some kind of birth injury or underlying neurologic disorder like tuberous sclerosis. There are other kinds of things that are also associated with seizures. People who have a family history of epilepsy, and kids who have severe receptive expressive language disorder. These 4 things have been identified as independent risk factors for seizures in kids with autism. But what I'll say is seizures can look like so many different things, as I was saying. I've listed up here some of the things that come to our attention as physicians to investigate as possible seizures. So kids who might have some kind of sustained deterioration in their behavior or level of functioning without explanation. Kids who have very sort of discrete periods, and this is where everybody starts raising their hand saying, is this my kid? Is my kid having a seizure? But you know, if a kid has this very abrupt change in behavior and then a very sudden change back into a typical state, kids who have staring spells or can't remember, you know, brief or long periods of time, and then kids, you know, they might be playing their video games and then they stop and then they just start again, you know, where there's this very brief change in what they're doing or how they're doing it. Those kinds of things are not all seizures. Don't get scared, but those are the kinds of things where if you see them happening over and again, I would suggest that you bring that to the attention of a person who can think about whether there might be seizure activity happening in your kid. Okay, so seizure management's basically the use of anticonvulsants. And as we talked about, anticonvulsants can also affect your mood and your behavior. And the benefit is that sometimes antiepileptics will help moderate those things. But again, there's no large clinical studies to test the effects of anticonvulsants in children with ASD and epilepsy. And I can't stand up here and tell you which seizure medication is going to work because we pair seizure type with seizure medicine. So this is the time where you would engage a neurologist, and that's who would help you sort out concerns about seizures, concerns about what medication to use. So I think in your slides you'll find this is just a little summary of classes of medicines and the kinds of things that they might target. And I think one of the basic core tenets of being a doctor is trying to find as few medications with as few side effects that do as little harm as possible when we introduce them. And when we can find one medicine that might target multiple things, that's great, that's a bonus. And if you have multiple things on your list, which is another very common question, so if you say, I have 6 things that I'm worried about and I want all of them addressed, what we try to do is start with one. We pick either the most easily addressed or the most challenging thing for you to manage, and we try to address that first and then see what's left. And then we might add, you know, a second medication to try to address what's next on our list. So gynecologic concerns, this is very brief. I'm just going to sort of put out there that lots of girls going through puberty are going to have mood changes. The physical symptoms may be so uncomfortable that you notice that there are cyclic changes in how kids are functioning or what their behaviors are. Sometimes it's just a matter of starting Motrin for the day before somebody is going to have their period, and giving that can sort of make them comfortable, and doing that preemptively is super successful. There's also a number of kids who can get put on an SSRI, which is considered an anxiolytic or an antidepressant, and even just in the few days around their period, that can help make them more comfortable in terms of their mood. And then for some kids who aren't able to sort of care for themselves and for hygiene reasons, sometimes the oral contraceptives are helpful for those who have to offer that care, just in terms of sort of having a more predictable schedule and making things sort of more comfortable. So I would encourage you to talk to your pediatricians about those kinds of things. They should be well versed in using them, if that's something that's on your mind. And then GI concerns. So even though kids come with so many GI worries, we cannot find anywhere a reason in the genetics or, you know, in any other sort of neurologic explanation as of yet why kids with autism have so many GI complaints. We know that they do, but we don't know why. We don't have any link to why autism would be related to so many of these concerns. We just sort of know that they are. Oftentimes your pediatrician is very capable of managing things like constipation and sensory changes with different kinds of foods. But this may be the time, if you're very concerned about growth and failure to thrive and ongoing symptoms, where you would either engage a gastroenterologist or a speech therapist can help with introducing new tastes and textures. And sometimes it's a behaviorist who can just sort of help work through the anxiety of new foods and sort of reward systems and trying to get sort of routine in place. So I'm happy to be a resource for anything that's on your minds, and if there are other kinds of experiences in the hospital that would be useful, if there's other questions that you may have about accessing the medical system. I would encourage you to find providers you're comfortable with and who seem comfortable working with kids with autism. I think if you're considering medications, child psychiatrists are probably the most well-rounded in terms of their understanding of the psychotropic medications. Lots of pediatricians and developmental pediatricians can get started if it becomes a more complex process. I would say that partnering with a psychiatrist is the way to go. Trying to find providers who will work together and talk to each other is, I think, imperative.